Hello, my name is Ashley Sanchez, and this is my presentation on systemic lupus erythematosus. Lupus is an autoimmune disorder involving the connective tissue. However, there are multiple organs in the body that can be affected. Lupus can present differently patient to patient and can present as mild disease, or by the time they come to the doctor with symptoms, it can have progressed into a more life-threatening stage of the disease. There are multiple chief complaints that patients come in with that are similar across. A lot of them will come in indoors feeling tired all the time, fatigue, lethargic, just lack of energy. They may complain of joint pain and stiffness in any joints of the body. They may complain that they've been having these rashes, whether it be on the chest, the back, the arms, the face. Some of them will come in with GI symptoms as well. And then another cue would be a fever with no other overt signs of infection. Skin issues are pretty common, as mentioned. The most well-known is the butterfly rash across the nose and the cheeks. Other common symptoms that you would see on physical exam as the healthcare provider would be lymphadenopathy, splenomegaly, hepatomegaly. The GI symptoms, of course, alopecia and Raynaud's phenomenon as well. Here are 5 differential diagnoses that can have similar presenting symptoms as lupus. The first important one to rule out would be HIV. If left untreated, this can lead to AIDS, which will weaken the immune system, allow for opportunistic infection, and can lead to death if left untreated. Second would be immunodeficiency, primary immunodeficiency. This you would see more in children who present with the juvenile lupus as a differential diagnosis. And they would have typically just fatigue, low-grade fevers. If this is left untreated, can also lead to severe illness and death. Number 3 would be autoimmune thyroid disease. An example would be Hashimoto's. They also present with lethargy and joint pain. If left untreated, this can lead to neurological complications and increase your risk of specific thyroid cancers. Number 4 would be rheumatoid arthritis, following the same pattern of symptoms: fever, lethargy, joint pain. They can have rashes as well. If RA is left untreated, it can lead to joint instability, including in the cervical spine, and also will increase your risk of certain cancers. And then 5th would be Epstein-Barr, as this particular diagnosis usually can resolve itself on its own. Obviously, depending on the chief complaint and presenting symptoms, you can try to narrow it down, but for the most part, these share multiple of the same chief complaints as lupus does. Pathophysiology of lupus is not completely understood. It is surmised or guessed that there's a loss of self-tolerance in the body. It's from both the innate and the adaptive immunity. As for the adaptive immunity, manifestations of that would be defective T cells, such as a low genesis of interleukin-2, and an increase in double negative T lymphocytes. In the B cells of the adaptive immunity, you'll have low levels of them, but they'll be extremely overactive, and they'll also be autoreactive. If we look at the innate immunity, the dendritic cells create an abundance of interferon type 1. They reduce nucleic acid complexes related to apoptosis, and then NETs are the neutrophil extracellular traps. One of the defining immunological features of lupus is the production of the autoantibodies with the elevated anti-nuclear antibodies, which we'll talk about in the laboratory section. These are the autoantibodies that can help distinguish if there's specific organ involvement in the body with lupus. Lupus, the average onset of the age of lupus is 16 to 55 years old. It is more common in women than men. Usually due to hormone differences, specifically estrogen, but also progesterone. So women of childbearing age are affected the most out of any other group. These are the patients that come in with the chief complaints listed earlier: fatigue, GI symptoms, rashes, joint pain, fevers, etc. 1/3 of patients with SLE will also have some type of cognitive impairment. It could be memory troubles, language, decline in attention span. Lupus can also present in childhood, called juvenile SLE. These patients typically present more aggressively than the adults do, and there's less of a gap between if it's males or females that are affected. Symptoms you can see in kids are shortness of breath, higher fevers, neurological insults that include seizures. You can also see nephritis, vasculitis. They might have severe thrombocytopenia by the time they present, and they can also have severe devastating complications such as diffuse alveolar hemorrhage, but this particular complication has a mortality rate of 20%. When older adults are affected, their symptoms typically are milder, and they may have a little bit different symptoms. You won't see the kidneys affected quite as much, or the central nervous system. You may see more joint manifestations in these patients, more pulmonary manifestations, and they also, a lot of the time, will complain about dryness in the mucous membrane, such as the mouth or the eyes. There's multiple labs that can be done to help with the diagnosis of lupus. A CBC with differential and a renal function panel are two of the first ones that are most likely done. This can rule out anemia, thrombocytopenia, neutropenia in terms of the CBC. And then the renal function panel would show an increase in creatinine and a low glomerular infiltration rate to see if the kidneys have been affected. Protein levels in the serum will also be low. And if this isn't accompanied with hypertension, that can be a risk factor for lupus nephritis. And if this is suspected, you may do a renal biopsy to confirm. With the renal complications, a UA would be done in conjunction with the other labs to check for proteinuria. There are also multiple inflammatory markers that can be used in assisting lupus, such as decreased C3 and C4 levels. You would have elevated erythrocyte sedimentation rate levels and elevated C-reactive protein levels. These tests should be used in conjunction with labs that test for specific antibodies for lupus, such as the anti-nuclear antibody testing. These can get even more specific to include anti-dsDNA or anti-Smith antibodies. There's also diagnostic studies that you can do, such as chest x-rays and echocardiograms, to show any lung manifestations such as pleural effusion or any valvular disease or pericardial effusions that may have come up as a complication of the lupus. And then in children, there are also other ANA detection that you can do, such as the anti-Smith, anti-RNP, the anti-Rho, or the anti-LA. In kids, you want to be more aware to check renal function panels, CBC with differentials, and radiographic imaging. These patients are at a higher risk of renal and respiratory manifestations, and they are typically more severe than the adults. There are multiple different therapies now that are used to help treat systemic lupus erythematosus. There is not much of a difference in treatment between children and adults. There's not different criteria for the both of them. Medication dosing will be different based on weight. The first line of defense is typically the anti-malarial drug hydroxychloroquine. This one is weight-based. For all of these drugs, you want to use the smallest dose possible when prescribing. That will help control symptoms. If the hydroxychloroquine by itself does not work, glucocorticoids can be added in conjunction with those, or corticosteroids. If these two do not work, then if a third therapy is added, it would be an immunosuppressive agent, specifically the DMARDs group. There's multiple choices of these. Most commonly used in children is rituximab And then if a child is greater than 5 years old, belimumab is used. But most of these medications are only studied extensively in adults. And in adults, the first DMARD typically chosen is methotrexate. There's also azathiprine and mycophenolate mofetil that can also be used. And these are dosed depending on the severity of the disease that you had. Cyclophosphamide can be added for life-threatening lupus if you haven't had a response to any of these other medications. With lupus nephritis or cutaneous lupus, especially in children, calcineurin inhibitors, cyclosporin and voclosporin may be added. You can also use these for adults, and topical glucocorticoids can be used for the adults as well. These patients, as I said, must be assessed and started only if the medications are deemed necessary at the lowest dose necessary, especially in children. These patients have to be monitored very frequently with lab work and follow-ups. Lupus patients may also need to start anti-epileptic medications if they're having neurological manifestations of the disease, as well as these patients should be screened for depression and referred to psychiatrists and medical management of that as well, as they do have a higher risk of depression. Lifestyle changes are also very important for these patients. Protection from the sun, they should have education on wearing sunscreen and wearing hats. They're more prone to sun damage, and some of these medications can potentiate that as well. Patients should stay very well hydrated and eat a diet that is anti-inflammatory. A good example to give your patients would be the Mediterranean diet, including things like fish, vegetables and fruits, beans, and whole grains. A healthy weight should also be educated on. They should not be too light, but they should also not be overweight as well, as overweight can potentiate inflammation. These patients should receive their vaccines as they are immunocompromised, and they should prevent being around people who are sick. They need to follow up frequently with doctors so that they make sure they're on the correct regimen and all of their lab work and assessments look well. And then these patients do require lifelong monitoring. And a few other things for education: they should also have their eyes checked and their bone density checked, as they are at higher risk for visual loss and for osteoporosis. In the United States, in terms of cultural and socioeconomic considerations, the highest minority occurrence of lupus is non-Hispanic Black women, followed by Hispanic and non-Hispanic Asian women. The group with the lowest prevalence was non-Hispanic white men. Deaths among minorities are also not distributed evenly. The group that's found to die 13 years younger is African Americans versus their Caucasian counterparts. These patients also have a higher risk of death if their lupus is associated with lupus nephritis that's caused end-stage renal disease. However, if you look at these same patients and consider whether or not they have health insurance and what their median household income is, the disproportion disappears, showing that socioeconomic status does make a difference in the management of lupus. Mortality rates found also to be lower in Hispanic and Asian patients. Most of these patients had Medicaid status and were able to see doctors and be followed with their disease. In the hospital, there are more hospital deaths than Blacks or African Americans, Asians, and Pacific Islanders. South Americans are diagnosed earlier, typically in their early 20s to 30s, mostly women. And then Asian patients, there's seen to be a more severe presentation and course of the disease and a higher prevalence of nephritis. And then back to socioeconomic status, patients with less education were seen to have more poor outcomes when it came to their lupus. In lupus patients, 50% of these patients will experience renal disease, and relapses in the renal disease are common. It is one of the most common causes of morbidity and mortality in these patients. However, the most common cause of morbidity and mortality in lupus patients is cardiovascular disease, including but not limited to premature atherosclerosis, hypertension, coronary vasculitis, and Liebman-Sachs endocarditis. These patients are predisposed to more frequent infections that are attributed to death. Despite this and other complications that you can see with the disease, earlier diagnosis and effective treatment has given adults a 10-year survival rate of around 91%, and then more than 80% of patients living with lupus are expected to live an average lifespan. And juvenile systemic lupus erythematosus, diagnosis is not always prompt as adults due to atypical presentation. So in order to decrease morbidity and mortality, aggressive treatment and early diagnosis as possible is key to beneficial outcomes. Childs still do have slightly worse morbidity and mortality rates. They have a 10-year survival rate of around 85% versus 91% in adults, and they have worsened involvement with their kidneys. Medication and treatment plan adherence is probably the number one teaching and education point that you can have with your patient, as well as them knowing side effects and signs and symptoms of flare-ups. Patients should look for adverse medication reactions or flare-up symptoms such as an increase in their joint pain, acute onsets of fever, new or recurrent bleeding from anywhere, sudden weight loss or weight gain, any new type of abdominal pain or discomfort or upset, and any new or recurrent cutaneous lesions or rashes. Frequent follow-ups with doctors are important to monitor disease activity, as well as regular eye appointments and musculoskeletal exams. Cognitive and depression screenings are very important. Lupus inflammatory effects can potentiate the decline in cognitive function and mental health. These patients should know the components of a healthy lifestyle in lupus, including the anti-inflammatory diet spoken about before, avoiding fast foods and foods high in cholesterol and fats that are processed. If the patient's overweight, education on weight loss and why it's important, not just that they should do it, and healthy diet and help about that. You can refer them to a nutritionist if need be. These patients should also keep up on vaccination status, especially if they're on immunosuppressive therapy, as well as staying away from sick people, and if you're around, wearing a mask and keeping yourself protected. Sun exposure should be a good teaching point as well, making sure that they're putting on sunscreen, they're putting on hats, that they're limiting their time in the sun as much as possible. If they're having mental health issues, it's an important thing to discuss and refer them to a psychiatrist or even just a psychologist. There are support groups for lupus that they can join. And then, like before, spoken about knowing the symptoms of flares, as if a flare is not taken care of accordingly, it can potentiate organ damage. And then as for the special populations of children and pregnancy, in pregnant women, there's multiple complications that can be had, including miscarriage, preterm labor, preeclampsia. Their medication should be managed very carefully. They have an increased risk of thrombocytopenia, and they need to follow up more frequently with their OBGYN than the typical low-risk patient would. Teaching for children and teens should include knowing their symptoms, especially the teens, the parents knowing the symptoms and the signs, and knowing that if there's any change of the child in baseline, even if it doesn't seem like a typical symptom, that warrants a call to the doctor to follow up and get checked out. And these are my references, and I hope you enjoyed this presentation. Thank you.